Thank you very much. Good afternoon. I know you guys have become sleepy. We'll try to go fast. First of all, in order to approach seizures, you've got to know what a seizure is. So we'll begin with definitions. I have no disclosures, and our objectives here are to review the definitions of seizures and epilepsy, then to outline the differential diagnoses, to differentiate different seizure subtypes, and to outline on how you're going to investigate a patient with seizures. And then we're going to go through the guidelines of treating patients with new onset seizures. So we'll define what an epileptic seizure is, what a provoked seizure is, what an acute symptomatic and a remote symptomatic seizure are, and unprovoked seizures in addition to epilepsy. So a seizure is basically a transient occurrence of signs and symptoms that are due to abnormal synchronous neuronal activity in the brain. Any sign and any symptom can happen, believe me. Provoked seizures are those that occur within 24 hours of an insult like drug or alcohol intoxication or withdrawal or exposure to ectogenic drugs or a severe metabolic derangement. And acute symptomatic seizures are those that occur within less than 1 week of a CNS insult like a stroke, like a traumatic brain injury, and an infection of the central nervous system. Remote symptomatic seizures, on the other hand, are those that occur within more than 1 week of a CNS insult. And unprovoked seizures are those with no identifiable acute insult or toxic metabolic factors to explain why the seizure occurred. Now, how we define epilepsy is if you have 2 unprovoked seizures that are at least 24 hours apart, or 1 unprovoked seizure with a more than 60% risk of recurrence within the next 10 years, or when you diagnose an epilepsy syndrome. So now when we approach a patient with seizures, how do we need to think? First, is it a seizure or is it a non-epileptic event? And then, if it is a seizure, is it provoked or is it not provoked? And what type of seizure is it? Generalized, focal, you've got to classify it. Where is your localization after that? And then should I treat or should I not treat? So, how do we make a diagnosis? History, physical exam, imaging, and video EEG. You take a proper seizure history. And the ways you take a seizure history is a little bit different. You always need to know what happened before the seizure, meaning to say the aura, what happened during the seizure, and then what happened after the seizure, the postictal phase. You need to know how long was the seizure and how frequent is it. And you've always got to ask about the risk factors of epilepsy, because that makes a lot of difference. You've got to know, are there any perinatal insults, history of prematurity, NICU admissions, febrile seizures, history of CNS infection, significant head trauma, stroke, tumors, or a family history of epilepsy. You're encountered with a spell. As we said, you ask yourself, is this epileptic or non-epileptic? If it's epileptic, you go and say, is it focal or generalized? If it's non-epileptic, is it physiological or behavioral? So if it's behavioral, think about psychogenic non-epileptic events or panic attacks. If it's physiologic, you might think about having a CVA or syncope, which is the commonest thing you're going to encounter in clinical practice, or one of the migraine variants. Going back to seizures, you classify focal or generalized, and then you go ahead. Now, we said syncope is the commonest thing you're going to encounter, and believe me, syncope is a big headache for us. And many times you will have convulsive syncope. So you've got to differentiate between a convulsive syncope and a seizure. And I'm going to tell you how to do that. Other differentials, TIA, complex migraine, dissociative disorder, psychogenic non-epileptic events, parasomnias, transient global amnesia, and medication intoxication. So there are certain clues that help hint towards if it's a seizure or if it's a non-epileptic event, whether physiological or non-physiological. Lateral tongue biting hints more towards an actual seizure. Eye closure hints more towards being non-epileptic. If the patient was standing and had the event, It can be a seizure, but it can also be syncope, and it's more likely to be syncope. You won't be having syncope when you're lying down. If you have a prodrome of diaphoresis, of lightheadedness, tunneling of vision, feeling warm, it's more likely to be a syncopal attack rather than being a seizure. Now, things like postictal confusion are seen after seizures and very rarely after syncope. Urinary incontinence, our residents always ask about that. Well, that can occur with both seizures and seizure mimics. Injuries can happen with all. Probably not with psychogenic non-epileptic events unless the patient is nuts. Especially burns will not happen with psychogenic non-epileptic events. So going to syncope. Syncope is preceded by lightheadedness, by dizziness, by sweating, as we said. Patient is pale, you have eye closure, variable movements. One thing you should ask or try noticing is if you have less than 10 jerks while losing consciousness for a short time, this is syncope. If you have more than 20 jerks, this is definitely not syncope. So the rule of 10-20. Less than 10 jerks, syncope. More than 20 jerks, seizure. Triggers of syncope: positional change, physical exertion, the Valsalva maneuver, heat, dehydration, and stress. Now, going into another differential, which is psychogenic non-epileptic events. These can be very long. Seizures are usually less than 3 minutes. Seizures will get aborted by themselves, but psychogenic non-epileptic events, long, variable, waxing and waning. While the patient is having the psychogenic event, the movement can wax and wane while you're speaking with them or trying to distract them. Entire body convulsions with maintained awareness, this happens with psychogenic non-epileptic events. Never does it happen with a patient with seizures. Eyes closed with resistance to eye opening, that's another thing happening with psychogenic non-epileptic events. Opistotonic posturing, which is hyperextension of the body, that happens also with psychogenic non-epileptic events. No head movements. No head movements, psychogenic. So this diagram shows us the difference. You look at the eyes, closed, psychogenic, opened, epilepsy. Head, no head movements is psychogenic. Opened eyes are seizures. Limbs, in-phase movements, seizures, and out-of-phase movements are psychogenic. Body axis straight is with epilepsy. Opistotonic is with psychogenic non-epileptic events. And rotational movements can happen with frontal lobe seizures, but they are less likely to be seizure, more likely to be psychogenic. Evolution, if it's continuous, it's a seizure. If it is fluctuating, it is not. Parasomnias occurring out of sleep, they're characterized by vocalizations and confusion, and patients may ambulate. CVAs or strokes or TIAs, you have negative symptoms, and they occur over seconds to minutes, and they won't be occurring every day like seizures. Now, if you think the event was a seizure, is it provoked or is it unprovoked? Causes of provoked seizures would include electrolyte imbalances, hypoglycemia, organ failure, alcohol or drug withdrawal, eclampsia, illicit drugs, and hypertensive emergency. Other causes of provoked seizures would include some medications, bupropion, cephalosporin antibiotics, some antipsychotics, INH, and tramadol. Now, one thing you should remember when approaching seizures and trying to classify provoked and unprovoked is the two terms we mentioned before, acute symptomatic and remote symptomatic. Acute symptomatic would fall under the umbrella of provoked seizures. Therefore, you should not treat. Remote symptomatic fall under the category of unprovoked. So here you might consider treating. Now you classify the seizure, focal, generalized, or unknown onset, and always look at the 2017 axis. We no longer use simple partial and complex partial. We go for focal aware and focal impaired awareness, and then we look at the motor onset or non-motor onset. I'll go a little bit quick as we don't have a lot of time. Now we try to localize the seizure, if it's focal or is it generalized. If it's focal, 4 major lobes. So temporal lobe seizures, the commonest thing you see in clinical practice. The classical auras that we see with temporal lobe seizures are the epigastric rising sensation. You can have olfactory auras, auditory hallucinations, and experiential auras like déjà vus and jamais vu and dissociative symptoms. Motor manifestations of temporal lobe seizures include automatisms, oral or manual. They would have contralateral dystonic posturing. They can have ictal spitting, post-ictal nose wiping, post-ictal confusion, and post-ictal aphasia if the dominant temporal lobe is involved. Frontal lobe localization implies very rapid, very hypermotor seizures with a lot of kicking and bicycling, and it can be nocturnal, out of sleep. Post-ictal aphasia would occur if the dominant frontal lobe is involved. Insular localization is a bit tricky. They would have pharyngeal dysesthesia. They would have a feeling of throat constriction. It's not respiratory. It is a seizure. They can have gagging. They can have dyspnea. And occipital lobe seizures can give you something very similar to a migraine aura, a visual aura. But the difference here is this is the type of things that an occipital lobe seizure patient would be suffering from, these circles. In migraine, you would have more of blurring and zigzagging. In occipital lobe seizure auras, it's more like circles and colors. Generalized seizures, as the name implies, you have a prodrome, and then you have the generalized tonic-clonic seizure, or you can have an absence, the famous absence seizure in children. Famous absence seizures occur for less than 30 seconds with rapid recovery. And you also have myoclonic seizures, which are a type of generalized seizures. They are single brief jerks, but they can often cluster. Now, you wanted to investigate the seizures, so you go and do neuroimaging. The yield is high. CT and MRI, of course, MRI is better. The yield of CT is 16% in one study, and the yield of MRI is 20%. CT readily available and detects lesions in up to 30% of patients with epilepsy. MRI, gold standard, helps us differentiate gray and white matter. Very good for focal cortical dysplasias. Lately, we've been having softwares that can detect these subtle FCDs. It's also very good for visualizing the mesial temporal lobe. EEGs, my passion and my love, EEGs. So the EEG yield after the first seizure is high. It shows abnormality in 12 to 73% of seizures. And if you have 3 EEGs being done, your sensitivity would be 84%. If you go to the 4th EEG, you go up to around 90%. It's important to capture drowsiness during EEG, capture sleep, because epileptiform discharges will be much more evident during stage 2 sleep. Now, the question that we have is to treat or not to treat. There was a study back in 1998 published in New England Journal of Medicine to look at how likely are you going to develop a second and a third unprovoked seizure after a first unprovoked seizure. And the likelihood of developing a second unprovoked seizure at that study was 33%. The likelihood of developing a third unprovoked seizure after the second unprovoked seizure was 73%. In 2015, the American Academy of Neurology published the guideline regarding the management of the first unprovoked seizure in adults. And the guideline summary was that adults with an unprovoked first seizure should be informed that their risk of recurrence is greatest early within the first 2 years. It accounts for 21 to 45%. Clinical variables that are associated with increased risk include a prior brain insult, EEG with epileptiform abnormalities, significant brain imaging abnormality, and nocturnal seizure. So one unprovoked seizure with any of these 4 things means you probably need to start treatment after consulting with the patient and looking at patient preferences and their job. Now, immediate anti-epileptic drug therapy as compared with delay of treatment pending a second seizure is likely to reduce risk of recurrence within the first 2 years, but may not improve quality of life. That's why we said you have to discuss the option with the patient. Over the longer term, which is 3 years, immediate anti-epileptic drug treatment is unlikely to improve prognosis as measured by sustained seizure remission, and patients should be advised that the risk of anti-epileptic drug adverse events may range from 7 to 31%, and that anti-epileptics are that these adverse events are likely mild and reversible. So the bottom line here is treatment with an anti-epileptic is not indicated for the prevention of epilepsy. Treatment after the first unprovoked seizure appears to decrease the risk of the second seizure, and the treatment decision should be based on the risk-benefit assessment, and treatment should be individualized considering comorbidities, social aspects, age, and gender. Thank you very much.